So when the patient is ready to fabricate the sleeve appliance, you're just gonna take the recent panoramic X-ray from them, just to make sure we check everything. We can look at the sinuses, the TMJs. At least we know how they look like before any treatment, and we're gonna also make sure if there is any teeth with the extreme bone loss or root resorption, anything major. At least we want to have the baseline and have a discussion with patient. Maybe if there is any treatment needs to be done, we're gonna do the treatment before fabricating the appliance, because as you know, these appliances are 3D printed nylon, and they have some limitations in modification of them, so we want to have the most accurate position of the teeth, the condition of the teeth before the fabricating the appliance, and it can last at least for the first 3 years. So we want to make sure if there is any major dental work needs to be done, we identify it before fabricating the appliance. So now I'm just going to demonstrate how we check the baseline of the TMJ and the muscles, and we also check the neck. Then we're gonna do the intraoral examination, check the throat, the tongue, we're gonna see the bite, we wanna see her in protrusion and excursive movements, if there's any tightness, any joint sound. It's good to have all the baseline, so later on when the patient is starting the appliance, and hopefully for many years to come, change is gonna come. They're gonna have some different symptoms and signs depending on how much we are pulling the jaw forward. So when we have the baseline, then we know if we are within the normal limits for that patient, or if we are getting too far and we have to step back. So the first thing that we're gonna check extraorally is gonna be the TMJs. So I gently keep my finger near the TMJ just to locate them, but then I release my pressure from TMJ and I ask the patient to open as wide as she can and close very slowly. One more time, very slowly. So I try to look for any sounds. I also ask the patient if they hear any sounds of clicking or popping. Also, it's good to ask patient if they had a history of clicking and popping, because sometimes the patient right now they don't have any clicking and popping, but there was a period of time in the past, maybe before their ortho treatment, or maybe sometime in the past that they had that period of clicking and popping, but right now they are not experiencing that. But it's good to also ask the patient if there is anything. Another thing that you can evaluate when you're standing behind the patient, as the patient open wide, and bite down slowly. One more time, bite down slowly. So you can check if there is any deviation in mandible on opening. That can come handy later on because the appliance keeps the teeth separated around 5 to 6 millimeters. So we want to make sure that during the first phase of opening, that is only the hinge movement of the joint, there is no deviation in the mandible. And one more time, bite down. She has a very slight deviation, but at the max opening, so it's not gonna interfere with the fabrication of the appliance. And then we're gonna also check for any tenderness in the TMJ. So you can ask the patient to open very little bit, few centimeters, good. And then again, you can put your finger near the tragus of the ear. So I'm exactly behind the TMJ, and I gently press forward. So I'm pressing on the back of the neck of the TMJ and also the disc tissue, and you ask patient if they feel any tenderness. Do you feel any tenderness on right or left? Perfect. So her TMJ is within normal limits right now, and we don't see any signs and symptoms. Now, in the second part, we're going to check all the muscles of mastication and also the neck muscles, and we're going to palpate them while the patient is clenching. But because a lot of time the patient don't know that if it's my finger pressure or if it's like soreness because the muscle is tired and sore, I'll always check it on their hand. So can you make a fist? So when I press here to this much pressure, do you feel any tenderness? No pressure. So I'm gonna apply the same pressure on your muscles. If it feels sore or tender, like you've been to the gym, then you know it's gonna be a tender muscle. It's good to communicate that to patients so they expect what level of tenderness we are looking for, because it's gonna be very minimal. Now, you can bite and clench hard. So what you're gonna do, you're gonna palpate the muscle, and you're gonna try to first run your finger along the muscle and also palpate a few points. So do you feel any tenderness here? What about here? So the masseters are seems normal. And now we check the temporalis. Yeah. Any tenderness here? What about here? Good. I'll also check the sternocleidomastoid. A lot of patients who have had history of sleep apnea and TMD problems, they may also experience some tightness in the sternocleidomastoid, so it's good to assess that. Also, as you see, by pulling the jaw forward, that's also one of the muscles that is gonna experience some pull on it. So if the patient feels tight from the beginning, it's good to have a discussion with them that maybe with some massaging or maybe changing the position of the sleeve or the pillow, that can also help as we are doing the titration for the sleeve appliance. So we know that if that tightness is because of the position of the jaw in a forward position, or from the beginning they had some tightness in that muscle. So I'm just gonna run my finger here. Do you feel any tightness or any tenderness in this muscle? And then, and as you see, the patient can just turn the head a little bit to the corner, and then you see the sternocleidomastoid muscle. What about here? No, good. And the next one, you can bring your chin up, please, and we check the muscles underneath the chin. Platysmus. Any tenderness here? Good. Can you also swallow for? We also check for any abnormalities in the thyroid, God forbid, which is pretty good. And the last thing, I want to check the muscles behind the neck. That's also sometimes can get affected with the oral appliance. So we're going to make sure if there's any tenderness, we know it from before. Do you experience any tenderness while I'm pressing here? No. Perfect. So for now, all the muscles extraorally, she feels very normal and it's asymptomatic. Now I'm going to check the muscles, few muscles palpation from the inside. For the medial pterygoid muscle, I put my finger in the corner of the mouth. You can feel the angle of mandible, and my other finger, I put it at the angle of mandible from outside, and I try to run my finger towards up. So medial pterygoid is parallel to masseter, but from the inside. And you ask the patient if they feel any tenderness while I'm putting my finger here and palpating it from outside. Do you feel anything here? Mm-hmm. Good. We do the same thing on this side. Go to the corner. No, please. What about any tenderness here? No. Good. And the last thing we want to check, we want to also check the insertion of temporalis into the coronoid notch from the inside. That's the closest that we can get to the lateral pterygoid, but is almost impossible to palpate lateral pterygoid intraorally, but it's a good approximation for us. So I want you to start closing. So I put my finger on the distal of the maxillary tuberosities towards the buccal. Any tenderness here? Mm-hmm. Perfect. So her muscles seem to be asymptomatic and normal. Next, we're going to check her occlusion. So open up, please. You can ask the patient to extend the tongue out, and if you look at the throat in this position, so you see, we almost see part of it. You can extend your tongue out. So I can see only a little bit of the base of the uvula and a little bit of the tonsils, more than almost half of the tonsils, and a little bit of the uvula. So she's myelopathy class 3 for me. And for the tonsils, I can give it a grade around 3 as well. In this position right now, she looks like she's class 4, but because some saliva accumulates at the beginning when they extend the tongue, that's more accurate. And then if you see, you can extend your tongue out and then relax it. You see the cannulations or scalloping along the tongue, so that's also an indicative of a higher risk of upper airway resistance syndrome and sleep apnea. So definitely she has a scalloped tongue. Can you put your tongue on the roof of the mouth? In terms of a tongue tie in here, she seems pretty normal and can bite down. And now in terms of occlusion, this will come very, very handy. So she is a class 2 molar and canine, and if I check the overjet, she has 5 millimeter of overjet, a little bit more than 5 millimeter of overjet, and she has around, like, open up please, around 50% overbite, and this overbite is a complete overbite, biting behind the upper front is impacting. And if you look on the left side, bite again please, you can see we have a, we have a posterior crossbite on the left side. So the posterior crossbite on the left side and also the excessive overjet, these are some of the factors that we have to keep in mind before making the appliance, because if we make the bite in an edge-to-edge position, which most of the time we're going to do that, we just want to make sure patient is comfortable in that position before fabricating the appliance, because even in the edge-to-edge position for Anna, we are bringing her lower jaw 5 millimeter forward. So I have to see what's her maximum protrusion. So if we are going to be on an edge-to-edge position in future for the titration, can give us a little bit better clue. And because of the fact that she also has some crossbite, unilateral crossbite posteriorly, so this affects the protrusive movement that she's going to have. I want to make sure that she's comfortable in that position. In the previous video, we talked about recording the bite using the bite fork, the double-sided bite fork. But this time, I'm going to use the single-sided bite fork with the George gauge. So as you know, George gauge also comes with some bite fork itself, but this is the George gauge, and that's our bite fork. So we can insert it, and then we're gonna put it at 0, and then we tighten it. So right now, 0 position, and then we're gonna make the lower portion loose, so this portion can move back and forth. And then when we are in position, we can tighten it. Now open up. So now we're gonna go this side. Now open up again. Perfect. So now I'm just gonna start loosening this. Can you bring your jaw forward as much as possible? Open up again. So you can go this side, is easier for you. Bring your jaw forward. More. That's the maximum we can bring. So I tighten it and I remove it, and I read the number here. So right now we are at 7 millimeter. So her maximum protrusion is at 7 millimeter from her original bite. Now I loosen it. Now try to bring your lower jaw backwards as much as possible. Go more. No, your teeth have to be in the thing. Okay, I think that's the max. So as you see, she can go for the retrusive movement almost 9 millimeter. So that means that she has a very good range. She can come to 6-7 millimeter protrusive and 9 millimeter retrusive. So we have around 15 to 16 millimeter of work. So if we start at the 5 millimeter protrusive from her habitual bite, we're still within her range of motion. So in that sense, I'm not worried about it. And also, we can check to see. You don't need to do that for all the patient. I'm just doing it for demonstration, but it's also a good idea to check to see if the patient is in the position that we checked. She's still gonna be comfortable. So now I'm gonna go like this. Now bring your jaw forward and close here. And then now I'm gonna check to see for any interference while she's in that protrusive position. It seems like pretty good, even though she has the posterior crossbite. We don't see any interference. I can open up. Again, for most of the patients, you may not need to use the bite fork, but it's a good adjunct to have for patients with severe class 2 or class 3 malocclusion. Especially I found that in the older population, especially older women that they have the severe class 2, they get a lot of strain on their jaw muscle when you're bringing the jaw forward. So because of that, they usually use the George gauge for them. But for most other people, if we use the bilateral bite fork, we can get the perfect biting, and it gives us a good clue during titration. We don't need to play around too much. At least we have an idea that what's going to be the most suitable range for the patient to get the benefit of the opening of the airway, but also not too much strain on the jaw. Again, we're going to review the scanning process. In the previous video, I want to show you that we want the scan of all of the teeth. If the last terminal tooth you have this much area of the missing data, that's acceptable, but not more than that. You want at least 3 millimeter of above the gingival margin, so it gives the lab a clue where to trim the appliance. And most importantly, when we recorded this bite, it was with the bite fork, so we have at least 5 millimeter of intraocclusal distance, and that's what we want. We can also check the lower scan just to make sure we have the details on all the teeth with the 3 millimeter minimum safety margins below the gingival margin. So it's very, very accurate, but it's still in your prescription you can communicate to lab that, for example, this is a baby tooth, has a severe root resorption, so I may ask for more relief around that tooth because almost has no roots left, so we don't want the appliance to have a strong grip around that tooth. But even if during the insertion period, insertion appointment, patient experience a lot of tightness along those teeth, it's very easy to put the appliance in a little hot water and just with your fingers or with some hot gun just to warm the appliance and just open the sides. So these undercuts, they're just going to get open and they put less pressure on those teeth. To this much, we can do some modification, but not much more than that. And again, as you see, it's very important to make sure we check the dental midline coinciding with facial midline, and if there is any offset between the dental and facial midline, we have to record that. And that's because the lip protrusion part for the airway that comes out of the lips, we want this to be in line with the facial midline. But the appliance is going to get fabricated based on the teeth. So if, for example, her dental midline was here, I have to communicate that to the lab that the facial midline is sitting 2 millimeter or 3 millimeter or more to the right of the dental midline, or vice versa. Usually if it's within 2 millimeters, it's not going to be noticeable, but anything above 2 millimeters, naked eye can notice it, and also patient can notice it if the lip protrusion part of the appliance is not coming directly in front of their nose and in the middle of their lips. So that's also another fact to communicate to the lab. But besides that, after everything is done, we're just gonna export the STL file and submit it to the website for the fabrication, and usually it takes around 3 weeks to get the appliance back, and then we start the titration phase when we get the series of band in the titration period.